Hello and welcome to Behind the Stethoscope. I'm Raisha Noorani and I am really excited to have Marilyn Graham join us today. Marilyn Graham has been a GP partner for over 35 years, and we've just spent the last few moments kind of thinking, wow, that's a really long time, Marilyn. And she was my trainer, so I am going to be slightly biased when I say this, but absolutely can I say guru of education, lots of pearls of wisdom. You've sat as a national representative for examiners at the RCGP. You are our in-house Croydon person to go to when we have questions about the MRCGP exam. And it's really a real pleasure to have you come and talk today. I really appreciate it.
It's a delight to talk to yourself and to your colleagues, and to have a fabulous training chat over hopefully a relaxed hour about what we're both passionate about, which is general practice. So it's great.
Fantastic. And I promise I did not pay Marilyn to say that about me. So I really just want to go right back to the beginning because, you do so much general practice work, but I want to kind of find out a bit about where did it start? So where were you, when did you decide you wanted to be a GP? Was it always the case? Tell me a bit about that.
Well, I have been told that about 4 somebody asked me what I wanted to do, and I said I wanted to be a doctor. So whether that's, I can't really remember it, but I've been told that that's what I was saying right from when I was a toddler. My mother was a GP, and her parents before her was a GP, and so I got used to mum being out at the surgery and perhaps dad coming home and collecting us, because that's the way it worked for them. So I think I was growing up in a general practice household, and when I went, I mean, there was no pressure. I have a brother and a sister, neither of those are medical. So just, we grew up but I always seemed to want to do general practice, or at least want to do medicine. And I went out of London. I'm born in South London, so I went out of London to do my undergraduate and my vocational training up in the Midlands. In Leicestershire and Coventry and around the Midlands. And as I say, went back there to do my GP training. And then, but I wanted to come back to South London, where I had many friends and family and connections. And in fact, it was some GPs that knew my mother very well, who said, well, as soon as Marilyn comes back, can you please come and ask her to come and chat to us? And they appointed me as a partner before I'd even finished my VTS, really. So I took a year off and did a bit of travelling, and then came back and joined actually a practice at Norbury Health Centre. Those 2 GPs have retired now, but and so I started my career at Norbury Health Centre as a partner with 2 other gentlemen GPs that are now retired. And that's how I started. And then eventually my mother was working also locally, and she said, oh, would you like to do something together? And I said, oh, that'd be fantastic. So latterly, and after I'd had 3 out of my 4 children, we asked what was the FPC, which was the authority then. It's to help us get a practice. So we never bought it, we just rented. They just organised it all for us, and so we have a practice near Norbury Health Centre called Fairview Medical Practice, and that's been going now 30 years. And then my mother retired, and other GPs joined me, but we worked together for a little while, which was sheer delight to have worked with her. And
that's amazing. That's amazing.
Patients still remember her. I think you'll probably remember Raisha, but many patients ask how Dr. Patterson is, and they still do, and and remember her very fondly. So that's how it all began, really. But yes, passion, always, even through the hospital jobs, although I was thinking about I loved them all. I loved paediatrics, I loved obstetrics. I was very interested in psychiatry and addiction particularly. I really thought, well, all of this can be done in general practice, which to me is absolutely so. This idea of having special interests and, in general practice has always been around, and very enjoyed taking my interests on and bringing back some specialist knowledge, as you do throughout your career, into general practice. I think general practice, you can do absolutely everything. That's the beauty of it. You can work more or less depending on your family, depending on, because you start at late 20s and you go on. To me, I'm in my mid 60s now, sorry. and I'd
Mid
like to be
50s.
in my mid-50s.
Mid 50s.
Um, but you can do absolutely everything, everything, and as you can increase your time or decrease your time as your family requires, so it works. But you can also, keep up a real specialist knowledge, go off and do courses, keep your learning up so that you keep interested and vital. And that's what I tried to do. Really, is.
Yeah, I love that. I love that. It almost sounds as though it was a sure thing from the beginning. You knew that was where you were heading. You had your eyes on the prize. That's where we were going. What did you have wobbles? Did seeing your parents,
Yeah.
be a GP make you think, oh, I don't know if
Oh
bits of this are not for me?
no. I mean, my mother will still talk to me in her mid-90s now about patients. Say, oh, how's that lady doing? She remembers names and things. No, I never had a wobble. I mean, the only thing was I did think about whether I'd like to do paediatrics, and and I've always been interested in paediatrics and women's health.
Yeah,
So, but I took that interest into general practice. I thought, well, I won't lose that, and I wanted to have a family, and I thought that's going to be hard doing what was then 1 in 2s and 1 in 3s in
yeah,
paediatrics. I thought that's really hard to have that much time away from your family on a regular basis for many, many years, probably ongoing if you're a consultant. So I thought that's going to be, it's not really how I want to do it, and I want to. So general practice just, so if there was a wobble, it was a little bit, but
yeah,
and I think if I'd been on, I was never unhappy in general practice. I always loved it. I've always had nice people to work with, and I've always enjoyed just going to work, seeing patients, talking to patients, getting good teams. I mean, and latterly getting great teams, and hopefully having. It's been very lovely to have lots of. I mean, you can imagine over the years I've had many, many medical students and many, many trainees with me.
yes,
They're all because they're all different and they all have different wants and needs, and trying to inspire them to love medicine, and to bring out their best parts and to try and help them if they've got any issues has been very enjoyable and stimulating. So it's never been boring. No 2 days are the same. And what people can actually sit here and be lucky and say, I can go to work, every day will be slightly different. It's always going to have something to make you smile in it. Even if it's someone brings you a cup of tea or somebody says something funny. But often it's the patients that some lovely patient said to me today, haven't seen you for a while, but you're very good, aren't you? I roared with laughter because I mean it's just such a funny thing to say. It just made me really really laugh, to be honest, this morning.
Yeah, I,
You know,
I I still remember to this day we had a patient, and I think I went through it as a trainee, and the standard history examination, and said, "Oh yeah, this is a tonsillitis," and said, "That's a bit more interesting than that, Aisha. Have a look. These patients are a bit like onions, and you've got to peel away a bit more. What are you looking for?" And it sounds to me that is what completely motivates you.
totally.
It's yeah, yeah,
Yeah, it's
absolutely.
not. If you think that people talk about general practice, they say, how do you cope with the colds? And if you think that listening to people tell me to describe a cold is that interesting after 30 plus years, of course it's not. But actually, why are they there? Why are they talking to you about their cold? Obviously, tonsillitis, they might be there just because they're really really poorly and they need some help. But there's always something interesting about that. So something
Yeah,
interesting about what why do they to come, why now, why me, why, and all of those questions. And so there's very very few consultations that couldn't be and are not interesting. And as you say, I've described it as peeling back the onion, but never get bored. I mean, and if it's about tonsillitis and you think, well, what else is going on and what else could I do with my time, my 10 minutes allocated, than just diagnose tonsillitis, I'm sure there's something I could do here, whether it be health prevention, whether it be some discussion about other members of the they've been worried about, maybe they came in about
yeah,
their children last week, and so you can say, and how are things going with that? I can see that you were here last week with X or Y, and so there's always something that's more. So if you find that you're in a boring consultation, you need to say, well, well, how can I make this not boring? What else is going on here? Is there
Yeah.
anything? And if you're lucky, and if it's just something as simple as tonsillitis with nothing else, well, it won't take very long, and then you can be on to the next very interesting patient. So I don't think any patient's ever boring.
I
Nothing's
love,
boring.
I love that, and it's the true. It's the almost basic foundation of general practice, isn't it? Because so many people that I've spoken to talk about find something else, and you sort of touched on have specialist interests, but it's the love of the kind of bread and butter of general
Yeah,
practice.
yeah. I mean, I agree with you, Raisha, by the way, that I think having interest. So I had the first year I was in general practice, I went and did a course at St George's 1 day a week on addiction because I knew I didn't know very much about addiction and drug addicts, and I did a day a week there under a very famous professor, and they did a drug addiction course for general practice. And at the end of a year, you were able to go in and work as a clinical assistant with. So I've always for that one we used to have. I mean, in the days where we sort of tended to work more 8 sessions or 7 sessions, and you'd have a day off or a day and a half off. On that day, I always did something else before I had children on something like drug addiction or rheumatology or pain. And
Yeah,
I continued to do a pain clinic right up to about 2 or 3 years ago at King's once a week, where I did weekly worked with the consultants, and I did a pain clinic. But I think there's nothing, and it's good to do other things that you can then bring in those skills to your general practice. And of course, it enhances your general practice, because what it does is give you, to peel back that onion, you need to have the knowledge, and you need to have ongoing refreshing of the knowledge. And so you must keep up your learning and interest and inspiration. So you can't just sit there and do 8 or 9 sessions of just that. You need to bring in other things. So education I brought and have loved doing that. And some of these other courses, I've done different ones throughout the years, and I've tried not to. Education has taken probably a lot of time, and the Royal College has taken a lot
yeah,
of time over the last perhaps 20 years, but certainly the first 10 or 15 years, I did all sorts of different clinical assistantships and learned a bit about more about this and that, which was really interesting. And I developed good connections with the hospitals and with the consultants. So, I mean, even now, I have a phone full of consultants' personal phone numbers and emails, and they're always delighted to have a chat about something, and so I think that I still think one can develop those relationships so that you have seamless care between primary and secondary care if you know your colleagues, and particularly if you've worked in a department. So I think that's a great thing. And if you haven't, and you've got someone else in the practice that has got that relationship, you can use that to help your patients.
yeah.
And so you get that, well, we really do need a bit of hand with this, so can we email that person, they give us a hand, and they're always happy to help. This idea that no one wants to help anymore, that's not true. I think it's what we're almost buying into, is this defeatist attitude that there is no way of discussing anything with a consultant. There is everything's faceless now. Of course you can email people and people reply.
Absolutely, absolutely. It's really interesting, isn't it? Because you're right. This is something we talk about a lot, and as we become, more and more digital, and we're
Yeah,
picking up the phone less and less, so it sometimes feels that that primary and secondary interface becomes really, very much a computer says no, your referral is not going to be accepted, and you almost forget, that actually it's the same way in which you describe, the RCGP talks about relationship-based care for
yeah,
patients, but it's the same thing. Having that relationship with your secondary colleagues has a
yes,
massive impact on how much not only the patient benefits, but you benefit internally, because you're not working there on a silo getting
yeah,
rejection letters from referrals and things like that.
absolutely. And I would say, if you get not every day, but if you get a patient that you get a letter back and they seem to have missed the point of why that patient went there, then just email them. My response has always been, oh yes, I see what you're saying. Let's have them back into clinic again.
Yeah,
Perhaps we have missed this, or probably my colleague didn't realise. And so I think we're all happy to relook at things and rethink about patients. And I think that the barriers that have been put up personal care. I mean, it's for efficiency and it's very important. And I love it that you can, send an email, ask a question,
Yeah.
get a reply. But nothing wrong with all these systems; they're great. But actually, sometimes what you want is your patient to be seen in the clinic. What they
Yeah.
need is their expertise. And if you sort of can develop some channels into these, or you have someone that can get a channel in, I think it's well worth asking the question. And I do find that my consultant colleagues are always open to having
Yeah.
discussions. There are very few of them that will say, I'm sorry, I'm not going to reply to a GP about a patient, or I've never experienced that. And we all have our good and bad days. I'm sure it can happen, but I don't think they're there primarily to help patients too, and we're all there primarily to try and help the patient the best way.
Yeah.
And I believe that actually still. I
I
mean,
like that. I can at the same time feel, hundreds of GPs suddenly going, but who has time for all of this?
yeah,
And, I think that's probably, or how can if I spend this much effort on my one patient, how can I stop myself burning out? Is that something you think about, or what do you think?
yeah. I mean, I did say the odd patient. I don't think, you may get a patient, once every 3 or 4 months that might really scratch you and your colleague's head as to what's going on when if you've got a good team and you really feel that you need a little bit of extra help. I do not think that either have GPs got the time, or should be spending the time, but
Yeah.
it needs to be a rare thing. But what I'm saying is it's there, and those are the patients, that we all have complex patients, but it's the ones where sometimes we need a little bit of extra help from a colleague, or we need to know that there isn't a problem there, so we can go ahead and do something different with them, and we need to be sure that this angles. And sometimes perhaps consultants don't quite understand why we're referring them. Sometimes it is to have the negative said, that actually to be able to complete the care and to complete the circle of treatment for that patient, we really need to be sure that there isn't another diagnosis, and that we're not missing something. And sometimes we need that as well. So there's all sorts of reasons why we make referrals to secondary care, and sometimes the forms don't always say it all. That's all I'm saying. I totally understand that we're all very busy and pressurised, and I do worry, a little
Mm.
bit, that we are very much, computer driven, protocol driven, and that many times I see patients, and you must see this, Raisha, too, that by the time they see you, they've perhaps been to pharmacy first, and they've perhaps seen a physician's assistant, and they maybe have seen a paramedic. They've certainly run 111.
Yeah.
They may have been to A&E twice, and by the time they get to you, they're in a right old stew.
Yes.
And you must be sixth or seventh appointment down the line over one, and actually something that probably if you'd seen them a month ago, it may have taken you back, 20 minutes to sort out. But now you have to unravel all the other illness and boxes these patients have been put into, and worries that have been created by tests, by inexperience, by lack of differential diagnosis, and all the stress and worry that's created now takes you many appointments,
Yes.
at a cost that is being eye-watering. By the time the patient's been through all this, the cost to the NHS is God knows what, but
Yeah.
huge. And you just think, are we really, really running primary care the way which is best for the patient, best for us, and best for the finances of the NHS? And I'm really not sure that we are at the moment. I think we've taken a slight turn, if I'm allowed to say that.
Yeah, I agree with you. It's, the focus on more and more patient contact, but perhaps less on the quality of that contact or the most appropriateness of that contact is where we sort of, I think, really do struggle. I mean, it must have changed a lot. 35 years ago, we didn't have an ARS workforce. We didn't have all of this sort of different.
No, but
Go
we
on.
had a midwife attached to the practice. We
Yeah.
had, funny this, I'll tell you, we had a real team. We had a midwife, we had
Hmm.
a health visitor who I knew by name, we had a district nurse who came in every week and sat with us to talk about patients. We had a CPN who came in and would see any mental health problems we had, and we did a session in practice, and we could refer anyone to that session, and she would see them, and then she would say, "This is what I think after seeing a couple of appointments, and she would then give us suggestions on what to do or whether to need to refer in. So, here am I saying that, we didn't have a team. We had loads of people. And I mean, we knew our district nurse, we knew our health visitor. We had a health visitor for the elderly as well. This is all
Okay.
Croydon based. All these people were assigned to the practice
Yeah.
and were valuable. But what did we do? We at one time we got rid of health visiting. We sacked all the health visitors in Croydon. We have just recently sacked all the elderly health visitors in Croydon. We had a fantastic team
Amazing.
that were resourced. We got rid of all of them. We no longer really have a named health visitor for each patient, and each practice doesn't have one. The district nurses, as you know, they're fantastic, but they're in teams, they're in very short supply. You may or may not get to know one. They may change. Croydon doesn't seem to be able to hold on to these teams because they don't pay what Lambeth is, and Lambeth is only 2 minutes up the road, and so
Yeah.
they don't want to stay in Croydon, and Croydon is a very heavy workload for them. So I don't think we've invested in the teams we've got, and of course none of these are ours workers.
Interesting.
And we're being now forced to spend money instead of saying to general practice, here is the funding, how would it benefit your patients in your surgery? It's
Yes.
not saying that. It's saying you must employ X and Y.
Which I suspect, I'm going to guess, probably wasn't the same as it was 35 years ago.
No, but I remember in the 1991 we all signed our resignations.
Okay.
Sent them
Okay.
back to, so what you're about, what seems to be politically happening now is not the first time. It's, in fact,
Interesting.
I think it's going to be the third time in my career that they have asked GPs to post date resignation letters and do it en masse. I mean, come on, team, we are the most important member of the care team to all patients. The one
Yeah.
person they want is their GP. With deepest respect, they may quite like their PA, they might quite like the district nurse that comes to see them, but actually, all the people they meet, they are most likely to want to see the GP again. So we
Yes.
have this power. Let's use it wisely, but properly. And I think we do need to say to the government, I'm afraid, you change every 5 years. Some of us are still going to be here 35 years later.
Absolutely.
You actually don't know what's best for patients, I'm afraid. They don't know. And I think we do need to be, it's not political, but I think we need to be clear what we need to do. And I think being imposed and told all the time, I mean, it's deeply, I mean, to be honest, Raisha, I tend to try and ignore most dictators tell me what to do. I mean, I go, fine. No way am I doing any of that. And I quite laugh to myself. Um, um, Medicine has not changed that much. There are changes,
Yeah.
of course. We've got better and better, marvellous medicines, but the consultation, the conversation you need with your patient is the bedrock of
Yeah.
all medicine and surgery. And without that, nothing can proceed. And I'm afraid I think we as GPs do it better. But I think we must not let the government take, or any political body say that we cannot talk to patients on a one-to-one, and actually we're going to give it to anybody else to necessarily do. There are, of course, fantastic things that other team members can do, but actually a lot. And I don't know what you feel, but I feel that I think we talked about peeling the onion a minute ago, but if you have got a really good basis of your undergraduate medicine, you're learning about consultation, you're understanding how surgical and medical conditions interact to make mental health conditions, your real understanding of the basis of sickness in patients, because of years and years of training and experience. With deepest respect, I don't think we can be replaced by physicians' assistants.
Absolutely.
And it's it's not cheap. The other thing is that
Yeah.
we are cheap, because what we can do in 10 or 15 minutes can send a patient out of the room feeling entirely relaxed without spending a penny on tests. Sometimes just
Absolutely.
doesn't happen with your colleagues, who tend to order an awful lot of investigations, I find. um, and I understand why they're doing it, because they want to be safe, but actually back to history taken many times, it probably wasn't necessary. And so I think in a way we need to revert it. We need to see the most experienced at the top of the tree, the doctors first. And then, of course, if that can be managed by a nurse, a physician's assistant, a paramedic, perfect. Then we send them for future measurement. The physios, fantastic.
Yeah.
That we send them to our first contact practitioner fairly early on, or if necessary, that it's obviously a joint problem, they can go straight there for exercise. But if it's not, then they need to come for a little bit of our skills first, a little bit of our magic before we send them off. And I think we need to sort of take back control, um,
Yeah.
and join together. In
Yeah.
a, I don't want to fight over money, but I do want to fight over our status, and from the point of view of it's actually what patients need. It's not,
Yeah.
I'm not being big headed about doctors. I'm just saying we've been trained to do that. That's what we're trained to do.
Absolutely. It's the value of the GP, isn't it? That's the bit that you're talking about. It's really interesting to see that you talk about, you've heard it almost a third cycle of where GPs are thinking about handing in their resignations. And you're right, there is so much disillusion, should I say, about where general practice is headed. You've seen it a few times
Mm.
and you've kind of remained stoic. Is stoic the right word? I don't know, or
Yeah, well,
enthusiastic.
absolutely. And I mean, I have to say, we mustn't underplay ourselves, because we are no government will want to fall out with general practice, because we see what, 1 million patients a day. I
Yeah.
mean, and it's not
90%
that
of
any.
it,
I mean, do I have any intention of withdrawing my neighbour? No, but I just think the mere
right.
intellectual discussion about what's going on needs to be had
Yeah.
with the parents. Say, or I'm not going to say it's about financial things, but I certainly think that when we're told that first line, I mean, I'm absolutely 100% behind all our doctors who are in training, 100%, that they need to know that people like myself and people of our generation will absolutely back them.
Absolutely.
But it shouldn't just be about money. It should be about having the time to do proper consultations. I'd like to hear more. And I'm to say I'm very into it. I'm all about teamwork, but I do think that GPs need to take back the importance of seeing a GP as part of as part of one of the people that patients need to see.
I guess that's starting to make me think about, you're in a very sort of special position, should I say, where you've seen teams when they work with your health visitor and how they worked in the past, where you had a named person and you
Yeah,
could go to them, to what is maybe a more contrived version of a team having the ARS staff,
yeah,
and how you can have a team, but that doesn't necessarily mean the same sort of thing. I mean, you're really impassionate. I'm listening to you and I'm feeling really rallied and suddenly a lot more positive about general practice, if I'm being honest, and the value of me as an individual, as a GP.
yeah.
Is that how you kind of found yourself taking on more with the college? How did that
Yes,
fit in?
I mean, if you ask me to name the one best decision,
Yeah.
other than kids and all the rest of it, marriage and kids and being a GP, absolutely adore it. It has been my college examiners, my colleagues. They have been the most fantastic friends I've had. I mean, and to have really good friends that think like you, that are
Yeah.
passionate about you. So, I mean, when I go to college things, in fact, these are the people I take my holidays with. They are as passionate about general practice as I am. So I know that I'm not alone. I mean, many of them are obviously at retirement age, and I don't think so many would have continued to work. Obviously, I am in this privileged position in that I'm in a fairly small practice, only 8,000 patients. I've got this fantastic team of wonderful receptionists, wonderful GP colleagues, fantastic nurses. My colleagues in our admin are just brilliant, and we feel, and then perhaps you'll remember it too, it feels a very friendly, kind, open place to work, and so it's very inviting to go to work every day, because it's such a nice place, and
Yeah.
you're very rarely in that what I think, and patients don't tend to kick off very much because it is a very relaxed place where patients know that they'll be treated with respect. But there aren't always appointments, and sometimes they do come in and say, "Oh, I've had to wait for an appointment," and all I can say is, "You can see we're all very busy, and there's a lot of demand now." I got demand, but I mean, my being an examiner has been absolutely fantastic, and it's given me that. I did say that I thought that everybody needs to do something for a day a week or something outside their own practice to keep a sense of proportion and find more new colleagues that have got some like interests. So education
Yes.
and teaching and education have been mine, and I met fabulous colleagues from teaching with John Spicer, who I think you interviewed as part of one of these podcasts. We ran an MRCGP course together in the evenings 30 years ago together. We were running courses where we did Thursday night courses, and we did it on behalf of the South London faculty. So we were running with Navchana courses on MRCGP and all sorts of teaching courses that we've done, So there are lots, and I mean, education isn't going to be everybody's buzz, but
Yeah.
you've got to find something that's your buzz that can refresh, that will give you colleagues that you can talk to about this passion that you have, and then you take that you're almost rejuvenated when you spend a day, and you take that back into the practice, and you take that enthusiasm and that smiling, and this is what I've learned, and isn't it interesting, and your colleagues go, oh yeah, that's really interesting, and
Yeah.
so um and getting together with your colleagues in the practice and telling them about what you're doing, and I think that has definitely kept me enthusiastic and fresh, and gets me through, because we all have terrible, by the way, I'm not stupid. We have days in the surgery where we really wish we hadn't got out of bed. Everybody gets those where everything goes wrong, from the IT to every patient's moaning that you've been running late, that nothing's gone right, and you just think, and then the patients have not been happy, and you've had a misunderstanding with one of them, and voices perhaps have been slightly raised. We all get to the odd day like that. I'm not trying to be, in la la land, but they're few, and to be honest, sometimes there are just bad days, and you just have to go, okay, I've learnt from it. Maybe I could do better. Maybe it wasn't my fault.
Yeah.
You know, um, and we just have to reflect that we all have our bad days, and but tomorrow is another day, and tomorrow will probably be better, and so but I really feel that having some little extra, Raisha, is the answer here, so that you can do something extra. It enthuses you, and you bring it back into your practice, and you bring a lot of joy with you from whatever it is you've learned, and but I mean, back to your previous question about being a bit worried about general practice. Of course, I'm worried about general practice. I'm worried the way we're being. Everything is enforced from government, but I think within your practices, you can make good teams. You can do things, within each practice. You can, by developing and changing things around, you can make it work. So never think that you can't make a change within your own practice team, and do it slightly better and differently. And I think and I'm sure you've taken that into wherever you've gone. You've taken ideas that you've learnt from all the different practices, and maybe even from our practice, and you developed it within your own teams now. And I think that's what good leadership does as well, is listen and be refreshed by everybody, and you can do things. So I think we aren't powerless within our practice, at least within our practice, and perhaps PCNs I think are slightly difficult because we're all thrown together and we're not very united.
It's
Sometimes,
another enforced one. That's the issue,
yes.
rather than it
Yeah,
coming
I
together.
mean, again, we were
Yeah.
made to do it. Nobody chose who they went with. It's got to be, and then there's now been a lot of splits, haven't there? And practices are going off because they're not happy with this. And I think I think it's full of difficulty. It's an enormous amount of money that government are pushing through PCNs, but again, it's in a disrespectful way, isn't it? It's telling you how you're going to. You've got to have this. You've got to do this. This is the money. You have got to. You can't employ a doctor or a nurse or a health visitor. You've got to do this because we tell you what staff you're going to be allowed to employ. So again, there's money, but it's being done in a disrespectful way. That isn't the way to do it, of course.
Yeah,
Um,
absolutely.
and I do think that we are going to need to have this discussion with the powers we be, because and there's no doubt the government, with our 1.2 million appointments a day, they definitely need primary care, and we need to be clear with them that we being told how to do something, well, it's not good, because look what they've done to the hospitals, taking away the firms and the way in which you worked in teams there. It destroyed the undergraduate.
Do you know what I think? I feel as though this is perhaps the first time in a long time where we don't have our patients' support and love in the same way we may have done in the past. I think there's a lot of negative, and I don't know if it's just media, because when I speak to my patients, they're very happy with me as their GP, but there just seems to be this onslaught from, the media portrayal of
Yeah.
of what people think about their GPs, which I think is new. I don't know, is it new? Have you seen that happen?
I think it's politically driven. I mean, there's no
Yeah,
doubt. I saw them do it with lawyers and with civil servants. I mean, who is it we're going to hate next? And this is definitely the government are punishing GP. They're punishing them for the quaff when they earned all those. They gave all that money to general practice. They didn't realise that a lot of practices were doing all of that, so they resented. They, they never asked, did they? They never asked, are you doing all this for you? And there's no doubt that it brought up some of the lower performing practices, but basically it gave us a wodge of money for a lot of us for doing nothing extra, because we were doing it all anyway. And so they were angry. I think the government I think they really, really dislike John, and I think they're putting it out there. But I'm not. I don't think the general public are stupid, and I think that, as you say, patients on an individual basis, other than I mean, I totally agree that it's the pressure on appointments they don't like. I agree with your worry. I wonder whether we and the BMA and general practice need to communicate what's going on more with our practice, and how we do that. I'm not sure. I wonder whether the college ought to be doing more about communicating with patients more, and whether we need to do, we almost need to be taking out sort of ads and get, with the Royal College saying, we would like more GPs, but actually there aren't training posts for them because the government haven't paid for them. The reason we've got 1,000 FY
yeah,
schools, 1,000 GP, 1,000 new doctors who are just qualified have got no jobs in the country is because they haven't paid the trust for them. So they're actually coming out of medical school and there's no jobs for them. Over 1,000. That's an absolute national disgrace when we spend all that money on training. So I think maybe we need to start being a little bit more proactive in our discussion with the general public. I feel that they understand that we're working as hard as we can.
yeah, they do. They do. I mean, almost 4 decades worth of sort of seeing patients and seeing this kind of the changes in general practice. There must have been, you talk about sort of some of the issues challenges we have now, but there must have been times where you thought, this is just a crunch point. I'm not sure I want to do this anymore. Or has that just never happened?
Well, I did say to you that there are bad days,
Yeah,
and I think that resilience, and I think we're all trained doctors. The resilience to say this has just been a bad week. I probably need a holiday. I mean, I think there are times where your battery feels pretty low and you've had a
yeah,
few bad days. I mean, I've always said to everybody, rather than save up all your holidays and perhaps go for a month, if you can take a few days off every couple of months is better than having perhaps a month off in August. Now you can't all do that because you've got children and you've got caring responsibilities. But ideally, getting too tired, things can get of you, and the bad days become more often than the good days. I think my advice is find yourself a niche, find yourself a practice where you feel supported,
Yeah.
where your colleagues actually know each other, say good morning to each other, or try and have a coffee at least once a week together, or a lunch or something, that you can knock on someone's door and say, God, I've had a couple of bad patients. Can I come and and I always just say, oh, come and sit down. Or I
Yeah.
go and see someone and go, oh God, Mrs. X was really difficult today, and they all go, oh, God, she's so difficult, isn't she? And it's that sort of support, and it's having that sort of within your team. So find yourself a team, build yourself a team, give yourself rests, give yourself a little bit of something different to do with colleagues outside your practice so you're refreshed. And try not to take worries home. I mean, the other thing is that I honestly, if you think you've done your best that day, then you probably have, and you don't take your worries home.
Yeah.
So
Do
you
you?
don't, you just don't. I mean, I'm not saying you leave your work undone. I say do your work, do it to the best of your ability. If there's a problem, let somebody know about it, and say, let somebody else share that problem with you if necessary. But don't take it home. When you actually go home, or when you actually log off your computer if you're working from home.
Do you think, Marilyn, that's how you managed to keep the salaried GPs stay for 20, 25 years? Is that, is it that team? I mean, I'm really getting that vibe of it's very much like having a team, finding your tribe.
You saw the team for at least
Yeah.
yeah. You saw our team for at least a year. I mean, you must have felt that you were slotted into a team where they cared about. I think I care about my colleagues. I care about my staff, and I care and they care about me. So I do think something about finding where you're allowed to blossom and grow,
Yeah.
and you're allowed to make mistakes. One of
Yes.
my colleagues said to me yesterday, the reason I I love it when I come here is that I know that if something's gone not quite right, somebody will be here to help. I never ever feel that I'm on my own. I never feel that I can't ask and I won't get help. Never ever. And I always feel safe. I always feel that I'm safe. It's always coming home. And I thought, because I hadn't seen her for a little while, I said that's really nice. Coming home. So
Yeah.
I do think and you do that by fostering that team within your team,
Yes.
and that's with the even
I love that.
the receptionists are important, as well as the practice manager. Everybody is important in that team, that you can go and say, today hasn't been good and this is why. Perhaps it's the IT, can you help me get that right next time? What is it that's made it a difficult today, a difficult morning, a difficult afternoon?
It's so different from, when you have this image of a GP, you have an image of a GP sitting in their room, door shut, working, you know, on their own. And yeah, I absolutely agree. I've been at your practice. It's absolutely nothing like that. And it's the same sort of things you talk about. So finding your tribe with with the other RCGP examiners,
Yeah,
having that relationship working. But it's the same value, isn't it, that you kind of have at the practice,
yeah,
which
yeah.
if you go off to do locums or sessional work, you miss that, don't you? It's
So
having a team.
I mean, there's nothing wrong with doing the odd locum, but this is not the way to foster your career. Because
Mm.
if you're a locum, nobody will come and sit and talk to you about that patient, or I saw what you'd done, and let me tell you what happened afterwards, and you get to talk about it. If you're part of that team, and a locum, I mean, there are long-term locums, and you can do, say, a maternity locum where you might be there for 9 months, so you really are part of the team. That's a bit different, isn't it? But and I can understand why people don't want to perhaps be partners. I understand that, but at least do salaried for at least a year or 2 years, rather than locuming here, there, and everywhere, because you'll learn. Because you know, why would I want to spend half an hour chatting about that lovely Mrs. Shah or something,
Yeah.
with someone that perhaps I will or won't ever see again. So from my point of view, if I'm having a locum, which by the way, we never have any locums in the practice. We never employ a locum ever. So we never ever, so they are banned from the practice. Now, I do, if we need more sessions, we can employ another salary doctor, and we can have as many doctors as everyone thinks we need, but they won't be locums. They'll come in, they'll do a substantial role, they'll come to the meetings, they'll come and eat lunch with us, they'll be part of the team, even if it's only for 3 months. They're going to be part of that team. They're going to talk about patients. They're going to bring their problems to that meeting. They're going to learn. They're going to share. They're going to teach us too things. And that's brilliant. But they're not going to be a locum. So, I mean, don't call yourself a locum. Call yourself, I don't know, a salary GP that likes to do maternity work. But be substantial in that. Go to the meetings. You can't expect the benefit of learning unless you're really in that environment, and you give it something of yourself. Then you get nothing out, so it ends up being horrible, stressful. You get nothing out of it, and it ends up being burnt out. So don't do it. Don't even consider doing, or just, I mean, do it for a couple of weeks or work out whether nothing wrong in taking a couple of weeks work in a practice that you're thinking of taking a salary job on, just to make sure that you do like it. But to be honest, within an hour you'll know whether that practice is right. Does somebody knock on the door and say, how do you like it? Do you know where the coffee's kept? There's biscuits there, and you've got Mrs. Jones on your list today, and she's a terror. That's you almost know by the end of a morning whether that's the right practice, Raisha. If no one's spoken to you and you leave at 5 o'clock in the afternoon, that isn't a practice that you want to be. If no one's come in and knocked at the door and smiled at you, what's the point? And that's part of this idea that you can do locums. You have to be part of that team. General practice is a team working. And if you're not, you can't learn from it. You will learn nothing. And so you'll be the same as when you begin, whereas you need to grow. It's like any job. You don't, as a young GP, you're only at the first stage of peeling that onion. There are layers and layers of that. And that takes a long time. And yes, you probably do get better with age. I mean, until you become no good at your job because you're too old. But that doesn't. You need time in the same way as you would expect a general surgeon not to be as good as if he's had 10 years experience. I mean, you don't want him when he's too shaky to operate. But if you're having a brain tumour removed, you don't want somebody who's just got there. You'd quite like somebody who's done the operation before, or has had opportunity to work with somebody more experienced. So you need to find somebody that you respect, somebody that is part of the team that you can go and be your mentor and take problems to. And every practice should have some form of mentoring, some sort of discussion where they know who they can go to talk to. So I like to pair GPs and say, who can you go and almost debriefing, except you don't. You may just have here's a cup of tea and a piece of cake, and there may be nothing to talk about. That's fine, you talk about the weather, but it may be that you want to talk about a difficult problem, and having that informality and having that meeting. And also you're learning all the time. You're thinking, is that why she's like that? Is that what happened 10 years ago? And is that why she was so angry today? Now I see what happened in that consultation. And then it all becomes clear, doesn't it? And then you think, wow, that's different. Now I understand, and I'm going to see her differently next week. And it's quite exciting.
I love that. I am going to catch you on something though. You talked about having 4 kids, being a GP, and I know that lots of us think, oh yeah, GP is really, it's the perfect place to be when you want to have kids and you can have all the flexibility. Is it really, Marilyn? What do you think?
Listen,
did it live up to the expectations of kind of managing motherhood and general practice?
I think it was. I mean, there's no doubt that having young children is tough. It's tough if you want to be a professional, because actually you can't just not turn up to work. I mean, I think I can honestly say, Raisha, that there's very few times I just didn't turn up in my entire career. But I do think it allows flexibility. For instance, if you've got young children, you can only manage to do 2 days a week, then you can drop down and you can do that 2 days a week. I think
Yeah.
you have to be honest with your team and say, this is all I can manage at the moment. But I'm sure I'd like to do more. In a year or two, but at the moment, that's all I can do. So I think if you're honest and you're open and you found your right tribe and you're embedded yourself, and then it can be very flexible. Yes, and I don't think you need support. Of course, you need good childcare.
Yeah.
I've always been I've always, I mean, I employed good childcare, so I didn't rely on, my mother, who was also working in the practice. She was
Yeah.
working in the practice. So, I mean, I employed good childcare, and I thought that was absolutely vital. So I spent a lot of my salary on very good childcare. And again, that was a privilege. I realised that maybe people can't afford that, but I think it's very difficult to pretend that you can be at home and do a surgery and you've got three children under four, which is what I had. I mean, you can't. I couldn't have done surgery if they were at home during the holiday. I wouldn't have pretended to be able to do a surgery and look after the children. So I think you can't have it always, but I do think that we can be very flexible. So, for instance, there's no time in the day when you couldn't almost run a surgery. So if the children's nursery allows you to be there from 10 to 4, well, I think we can use a GP between 10 and 3 or 10 and 4.
Yes.
I mean, if someone came to me and said, "Would you mind if I worked one day between 10 and 12, and then one day between 12 and 2, and one day between 2 and 6?" I'd say, just do it.
Yeah.
Do it. Make it work. If that's the way it works, Raisha, for you right now, make it work. When it works, if you can make that work and you can see patients and contribute. I mean, clearly, we're told that we've got to be open from 8 o'clock till 8 o'clock, and all of this.
Mm.
Again, the government thinks that we should be Tesco's or Sainsbury's open 24 hours a day. There's no need for primary care to do that. Unfortunately, we've allowed the government again to dictate and to pretend that we're just Sainsbury's, but we're not just Sainsbury's. And I don't think patients really need to see GPs necessarily at midnight at night. But I mean, that again has been a political stance that the government seem to
Yeah.
think is a good idea. But I mean, so my answer to your question is, it has been allowed. Yes, it's allowed me flexibility. I don't think I could have probably done it if I'd been a hospital doctor, but I don't know. I would have definitely tried to do it if I was a hospital doctor in the same
Yeah.
way. But I think we can accommodate. We're a broad church, or whatever the expression is. We can accommodate everybody, and we can accommodate all sorts of people. But I mean, I also, and all of the doctors working with us, they've all had children, they've all been on maternity leave. It's been fine. They've all been fantastically communicating. I mean, it's communicating, it's teamwork. Um,
Yeah.
and I mean, I think the message is get good, reliable childcare.
Yeah. 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 You're
I
right.
mean,
Absolutely.
how have you managed? I mean, you've also had to do all of this. It is about good childcare allowing you to some space to work, doesn't it?
Yeah, I think you're right. I think childcare is a massive thing, actually, making sure that that bit works well. And so that when you're at the practice, you can be at the practice and you've got your 100% game on when you're seeing patients and not distracted by, what might be falling apart at home. So I think that's really helpful. And I think, yeah, you're right in the sense that if you have the right place and you can kind of say, well, I'm going to go down, I don't think I can manage, the full day, or I can do X hours to X hours, and that's how it will work best for me. It is just temporary, isn't it? And
Yeah.
my children are still young, but they've kind of, they're older than they were when we were at the training practice, and you can see almost slowly how more of your time begins to be your own again, and it comes, and when they're in full-time school, you see changes. So it does get easier. Um, I would, if I'm being honest, I would say there was a point in when I was doing general practice where I just thought, how are these two things going to come together?
Yeah.
And it felt really far away, but
Yeah.
it's a brief sort of moment, isn't it? Until you kind of then go into the next chapter. And I guess
I
it's
think
kind of
those are the difficult days, Raisha, when you've got a sick child and you've got a surgery and the childcare goes wrong. Those are the difficult days,
yeah,
and you know, sometimes best will in the world, you just have to do what's right for you. And you know, if you've got good colleagues, it's not a problem, you know, because the colleagues know that you know, you would always, and they'll try and, you know, they'll come in a bit later, or they'll try and sort something out, or they'll do some prescriptions from home, or they'll do what they can later on. So it never worried me that you know, when my colleagues, you know, had a young family, and if I had a crisis, you know, sometimes, you know, would be a bit flexible, and people will be helpful, and that's why, you know, finding the place where you can you know, you can build the team around you. If you haven't got the team around you, you can't do it, and therefore it feels like it's a bit of a battle. Whereas if you've got a good team around you, they'll want to support you through a difficult time with a child, or, you know, a partner that's not well or something. It's just a matter of having that right team around you.
It's
And
a long-term thing, isn't it? I mean, you mentioned having a partner who's not well or whatever
yeah,
that might be
yeah,
like. There's some moments in life that
yeah.
just kind of, they're crunch moments, but that doesn't mean there's not a way around them in that.
And having elderly parents and things,
Yes.
responsibilities. You know, we are the sandwich generation, where we have, you know, children perhaps still living at home when they're grown up, and we have elderly parents that have got increasing medical needs, and so a lot of us have got that, and I totally sympathise, and feel, again, at different stages of your career, you have different personal, and it has to come together. So I think what I'm saying is, general practice allows that flexibility, but
Yes.
I think it wouldn't if you were being a locum, because you don't get anything like that. So find yourself a good team. You know, trust in your colleagues, that perhaps, if we're thinking about younger doctors, trust in the team you've got, that they will want to support you through these bad times, because the bad times are short.
Yes.
So that it seems a long time when you're in it, but in life it's short, and then you'll come out of it, and you'll have grown from it, and you will be bringing stuff back into that practice that enhances that practice, which is why, you know, all the doctors are trainers in the practice now. They're all, as their children are growing up, that they want to do more in the practice, and it's wonderful.
Investing in each other, isn't it?
Yes,
Because everyone has something to give, and they
100,
will find the time to be able to do that.
100%.
Yes, I love that. I love that. Marilyn, I could speak to you all afternoon, evening. We haven't even touched on some of the things about
Right.
examining and trainees, but I'm very aware that you've sort of donated your time to us to
Yeah.
talk to us, and you have, you know, it's so lovely to see. You can see how much you admire, you love not all the superfluous stuff, but the jobbing GP, the one who sees patients day in, day out, and still finds that interesting, you know, decades later.
Yeah.
Um, and your love of teams. You know, everything we've talked about today is the teamwork and the practice, the teams, what they used to be like, how they are now, finding your tribe. And you've
Yeah.
given, you know, trainees and I hope sort of newly qualified GPs, as well as sort of middle grade GPs who might be feeling a little bit, you know, lost a bit of enthusiasm for general practice, some real good pearls of wisdom. Sounds a bit
So
cliched, but you know,
hope
pearls
so.
of wisdom, which I think is something that we could all do with a little bit right now. So I think that's been incredibly
Thank you
helpful.
very much. It's been a real pleasure just to chat.
It is. Thank you.
Thank
Thanks.
you. Thanks. Bye bye, Raisha.